Yeah, good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and Med Talks, I welcome you all to the today's session on glucose monitoring. Today's session is brought to you by your hydration partner in diabetes in Result Zero. Before going forward, I would like to announce the last week winners. Last week quiz winners: Dr. Sanjeev Puri from Hoshiarpur, Dr. Anand Purande from Mumbai, Dr. Lakshmipati Bhupati from Vellore, Dr. Satish Kumar Jain from Bangalore, and Dr. Pramod Gupta. Now, I would like to welcome Dr. Sanjay Kalra, President-elect South Asian Federation of Endocrine Society, to give your views on blood glucose monitoring. Over to you, sir.
Thank you, Ankur, and good evening to everyone. It's the last Sunday of February. Let's talk today about glucose monitoring. Now, if you can't measure it, you can't fix it, right? So, if you have to fix glucose, you have to measure it properly. But measuring it is not just taking a glucose value and then keeping it there, parking it. You actually have to do something with the glucose value, right? So, let's talk today about glucose monitoring. We'll talk about different ways of monitoring glucose. And then we'll take questions as to how we can do it, how we can do glucose monitoring in a pragmatic manner, in a cost effective manner. Now, recently, the World Health Assembly set down 5 targets for glucose management. This is something very important. The World Health Organization, the World Health Assembly agreeing upon targets. So these are the targets in front of you. Diabetes should be diagnosed in 80% of all people living with the condition. In 80% of all people diagnosed with diabetes, we should have good glucose control. Now, that's a huge ask because right now we are running at 25-30%. But we have newer drugs available which can help us. But these newer drugs will help us only if we are able to measure the glucose. If you can't monitor glucose, how will you know whether you have good glycemic control or not? So these are targets 1 and 2, both related to glucose levels, diagnosing diabetes and controlling diabetes. Then targets 3 and 4 are that blood pressure should be well controlled in 80% of people diagnosed with diabetes, and statins should be taken by 60% of all people aged more than 40 if they have diabetes. So, two targets related to complications or comorbid conditions, uh, blood pressure and cholesterol. The fifth target we have mentioned here in 2 bullets, but actually it's one target from the WHO point of view: affordable insulin treatment and affordable blood glucose self-monitoring should be accessible to all people with type 1 diabetes. So see here, even WHO understands that glucose self-monitoring should be accessible to all people with type 1 diabetes. Glucose monitoring is linked with insulin therapy. You cannot have insulin without monitoring of glucose. And this monitoring should be affordable. So these are the targets. To achieve these targets, we have coined the concept of glycemic guardianship and glucometric guardianship. And I invite all of you to be part of this campaign, this movement. Glycemic guardianship means that at a micro level, I feel responsible for the glucose levels, for the optimal care of uh, my patients, those who live with diabetes. At a larger level, I am part of a team which wants to ensure euglycemia for the entire country. We have a right to euglycemia, all of us. So, whatever activities we undertake, whether it is education, advocacy, or whether it is treatment, pharmacological or non pharmacological, all these will come in the concept of glycemic guardianship. And these activities will also include monitoring because if I am guardian of glucose levels, I have to measure the glucose levels. That is why, along with glycemic guardianship, we have a glucometric guardianship. Now, let us look at this definition. It is a process, it's an ongoing process. So, it will continue forever and ever of ensuring. So, we are bound to achieve a particular target. We have to ensure that this happens. What happens? Appropriate, so that means the right. So, appropriate may be different for one patient, different for another. It may be different for one patient today and different tomorrow. So, there can be inter-individual and intra-individual variability. So, the process of ensuring appropriate measurement, monitoring, and analysis of glucose levels. So you have to measure, you have to monitor, and you have to analyze. You have to get the trends. You have to analyze. So as to what are we going to achieve by analyzing these glucose levels? We'll be alert, we'll be vigilant in terms of glucose management. So alertness and agility. Agility in terms of anticipating and detecting suboptimal glycemic parameters, which can be hypo or hyperglycemia, either of them, and then responding to them. So let's look at glucometric guardianship again. It is a process ongoing. You have to ensure appropriate measurement, monitoring, analysis of glucose levels so that you can ensure alertness and agility while managing glucose and dysglycemia, and also while responding to dysglycemia, whether hypo or hyper. This glucometric guardianship can be done in general, by three ways. So one is glucose monitoring, blood glucose monitoring, SMBG. The other one is continuous glucose monitoring, and the third is HbA1c. We'll talk about these one by one, and we'll look at some new terminology as well. So our recommendations are that glycemic status should be assessed at least twice a year in patients who are stable and who are on treatment goals. But if your patient is not doing well, if the therapy has changed recently, if there is a lot of fluctuation in glucose levels, or they are not meeting targets, then you have to check at least quarterly. It's at least quarterly. You can do an HbA1c every month also if you want. Sometimes we do it in pregnancy because 50% of the HbA1c is weighted by glucose over the past 28 days. So you can check more frequently. Somebody with an HbA1c of 13.8, you are anticipating very rapid change in ambient glucose levels. You can check after 1.5 months also to see whether you're on the right path or not. The numbers tell you that you should give insulin in a particular patient. You decided with the patient to give a finite treatment with non-insulin drugs. Don't wait for 3 months. You can check after 1.5 months to see whether we are on the right track or not. If we are, well and good. If not, then we shift to insulin. The glycemic goals are also laid down, and for the vast majority of non-pregnant adults with diabetes, we would aim for an HbA1c less than 7. In pregnancy, we would want it as low as possible. A pre-meal glucose of 80 to 130, that is what we aim for, and a post-meal glucose of 180, 140 to 180. That again is what we aim for in the vast majority of patients. But if you have patients who are elderly, at risk of hypoglycemia, those with renal or hepatic impairment, those towards the end of life, then you can relax these targets. For younger people, you have to have more stringent targets. Though we are speaking only of blood-based methods of monitoring, urine sugar is recommended as a monitoring tool for elderly people towards the end of life. So towards the end of life, you don't have to prick the patient too much. A urine sugar should suffice. If you check all these glucose values, how do they help you? So we have the concept of structured glucose monitoring. That means you have a structure. So how do you create that structure? If I'm giving metformin at night or basal insulin at night, then I will monitor with fasting glucose frequently and every now and then postprandial. If I'm prescribing pre-mixed insulin, then I will monitor initially with pre-breakfast and pre-dinner. Pre-breakfast and pre-dinner. Once those are normalized or optimized, only then will I go on to checking postprandial glucose. If it's intensive insulin therapy, that is basal bolus, then we will do multiple testing. It can be 7-point profile or it can be paired testing. Paired testing means pre-meal and post-meal. So if I want to check whether my lunchtime dose is adequate or not, I will do pre-lunch and 2 hours post-lunch. Post-lunch glucose is very high in persons who are on corticosteroids. So in those who are on corticosteroid therapy, the post-lunch and pre-dinner glucose must be checked. So structured glucose monitoring because you have a structure. Paired glucose monitoring for postprandial, and fasting glucose for checking whether basal insulin is adequate or not. Sometimes you will have patients with very variable glucose values. So at times the fasting may be 80, at other times it may be 280. Now you're not sure what is happening at night. Maybe glucose levels are falling down at night. Patient is in severe hypoglycemia, hypo. This is called Somogyi phenomenon. So how do you differentiate between Somogyi phenomenon, which is rebound hyperglycemia, and dawn phenomenon, which is hyperglycemia because of inadequate therapy? The therapy that we give at night is inadequate in handling the glucose surge that occurs with the release of counter-regulatory hormones in the morning. So for this, you might wish to do a pre-dinner, a post-dinner, maybe a glucose at bedtime, and at 3 a.m. 3 a.m. is the time when glucose levels are lowest in the body. There is maximum insulin sensitivity. And then fasting when the patient wakes up. So if you do these for a few nights, you'll be able to figure out whether glucose levels are falling at night or not. And you'll be able to decide whether to reduce the glucose lowering treatment. These nighttime values will also tell you whether you have to shift from long acting or intermediate acting insulin to an ultra long acting insulin. Supposing glucose levels are okay till 4 or 5 a.m., but then they begin to rise after that, then maybe the patient would benefit from shifting to degludec or U300 glargine, which are ultra long acting. This is structured glucose monitoring. Another advancement in this is IPDM, uh, individualized, uh, integrated, personalized diabetes management. So here what happens is many of our meters are equipped, they are cloud enabled. So whenever you check a glucose, it goes on the cloud, it gets recorded. So you can get your values, you can get your data, you can get it in very pleasant visual formats from these meters. So this is about self-monitoring of glucose. But another way is called ambulatory glucose monitoring. Another name for this is flash glucose monitoring. And yet another name is IS, intermittently scanned CGM, continuous glucose monitoring. But because you can scan the machine intermittently, you can scan the sensor intermittently. Ambulatory glucose monitoring, there are two models available from the same company. Either the patient applies a sensor on the upper part of the left arm. The reader can be with the doctor or it can be with the patient. So that is up to the patient to decide, and the patient can keep on checking glucose himself or herself, or they can come to the doctor to get it read. When will ambulatory glucose profile be suggested? If there is discordance between clinical features and lab values. Patient has a lot of complications, but the lab values are normal. Or patient is doing very well, but glucose levels are all over the place. So discordance between clinical features and lab values. Second is discordance within lab values. HbA1c is high, but SMBG values are good. Or SMBG is normal, but some SMBG values are very high. So let's see what's going on. So the first two indications are discordance, clinico-biochemical discordance, or HbA1c and SMBG discordance, biochemical. The other two indications relate to quality of control. So the third indication is where you want a very tight control. You want to be in the Goldilocks zone, neither too much nor too little. For example, pregnancy, you want very tight control. Fourth indication would be where you are faced with a lot of variability or inconsistent reports or refractory diabetes. You just don't know what's going on, so you need help. A fifth indication is when HbA1c is not reliable. For example, patients with severe anemia, with renal failure, with thalassemia, sickle cell anemia, other hemoglobinopathies. So where HbA1c is not reliable, how do you monitor for long-term trends? Either uh, AGM, ambulatory glucose profile. The other name is, like we said, ISCGM, intermittently scanned continuous glucose monitoring. Or maybe a serum fructosamine can be done. So that's another option. How do you get a value of ambulatory glucose? This is what it will look like now. You will get glucose values for 14 days, and they'll tell you how glucose levels behaved, how long they were within target range. You can set the target range yourself. How long, what percentage of time were they low, and what percentage were they high. In this patient, for example, we see that the average glucose for the past 14 days was 175 milligram percent. Had an HbA1c been done for those 14 days, it would have given us a value of 7.5, which is not so bad. but the glucose variability is quite high, 45%. And when you look carefully, 44% of the time the patient was above range, and time above range was 44, time below range was 10%, and time in range was only 46%, where our target is a minimum of 70. So this is AGM, and this is becoming more and more useful in practice. CGM, the CGM devices are also used. 5 days of glucose monitoring is offered with these devices, and you can measure interstitial fluid glucose levels. Again, numerical and graphic data both are available. Patients can respond proactively to their glucose data, and the continuous glucose monitoring that you get now with the pumps, with the newer quality of insulin pumps, is able to, it has artificial intelligence, it's able to predict hypoglycemia before it occurs. So it is able to pick up trends and offers the ability to take preventive action. So you can catch the hypoglycemia before the hypoglycemia occurs. It is important to use all these, whatever is possible for your patient, based upon cost, based upon availability, because if you are able to give good glucose control and keep your patient within range, maximize the time in range, you will be able to reduce complications. Let me remind us all of the definitions for hypoglycemia. Just 2 more slides to go. So level 1 hypoglycemia is when the glucose is between 54 and 70. Level 2 is when it's less than 54 milligram percent. And level 3 is any severe event where you need third-party assistance. There is altered mental or altered physical status, and you need help to manage your hypoglycemia. This is when you need help. Supposing my glucose is 55 and somebody gives me a glass of maybe Enerzal Blitz, that doesn't mean I have severe event. The person gave it to me, but I could have taken it myself as well. But if I'm so weak, my hands are shaking, and I'm not able to think of, or I'm not able to reach out for the Enerzal or Enerzal Blitz, then that's a severe event. And hypoglycemia awareness is something that we should be aware of at all times in diabetes management. So we've spoken about today we've spoken about glucose monitoring. Let me take some of the questions. So now Dr. Ramakant Sharma says reliability of glucose monitoring by glucometer. Yes, it is reliable. Take any good quality company. Try to take a company which has got after sales service, which is available in India. It would not be nice to take names, but avoid using these glucometers, where there is no after sales service, there's no one meeting you. They're made in various countries of East Africa, East Asia. And I am reminded of this song in Hindi. So the song goes, and Mickey Virus is the name of the movie. It's a Hindi movie where you get a very strong feeling of Haryana. तो वो गाना गाता है कि प्यार चाइना का माल है, लव इज मेड इन चाइना, प्यार चाइना का माल है, चले तो चांद तक, नहीं तो शाम तक. It can continue until the moon, that is forever and ever, or it can disappear by evening. तो प्यार चाइना का माल है, चले तो चांद तक, वरना ये शाम तक. And same would be true for some glucometers. We are not aware of their provenance. So you can use the glucometers. In fact, according to ADA, you are supposed to use venous sampling for diagnosing diabetes. But according to WHO, you can use glucometers also to diagnose diabetes. So according to WHO now, latest update, glucometer can be used to diagnose diabetes as well. And another very insightful question from Dr. Sharma. What percentage of other saccharides are there in blood? There are, but they do not contribute to variation in glucose levels. So glucose is different and sugar is different. So there are different types of sugars. The only thing that will impact glucose levels is ketosis. So if you have ketones, then the glucose may come as artificially low. How do we explain to patients? So where I work, we live in the sugarcane belt. So what we tell them is that alcohol is also produced from sugarcane and glucose is also produced from sugarcane. So if you cut the sugarcane crop in time, you get glucose. If you cut it too late, it gets fermented and then you get alcohol. So same way, in case glucose levels become very high in the body, then you will get ketones. So you say that it's not alcohol, but it's a type of alcohol. And then when you check with the glucometer, you may get a low value of glucose. But that is misleading, because actually, if you were to check the alcohol, if you were to check the ketones, then you would get high values. How do you check ketones? There are meters for blood ketone. The same meter can be used for plasma glucose and for ketones, but the strips will be different. A strip for checking ketone will cost around 200 rupees. Or you can check with urine ketones. So that is quite cheap, very economical. With dipstick, you can check. So urine ketones can also be checked. Do remember that urine ketones are graded as uh, trace, small, moderate, and large. Trace, small, moderate, and large. That is how urine ketones are graded. And we should be aware of this difference between sugar and glucose. So what I would request is that we begin requesting our labs to write glucose, because that is the right word actually. Many more questions. And Dr. Gauri Shankar Dharmaraj from Karnataka says, ointment in paresthesia, not good quality evidence. So it might have placebo effect. Otherwise, it is not going to help much. You can tell your patient actually to apply coconut oil also. Even that will help. Thank you for your kind words, Dr. Dharmaraj. Vitamin D, yes, Professor Nitin Kapoor is one of our best teachers. He comes from CMC Vellore. And we will be having more KK Med talks on vitamin D, 3 more, I think. The next vitamin D KK Med talk, if I'm correct, will be on the 6th of March, which is a Thursday. I think so. Greetings to Dr. Vinayak Sharma and Dr. Nitin Narula as well. Sublingual vitamin D 1500 microgram daily would not be required. Once a week should suffice. And namaskar to Kripashankar Singh ji and Dr. Arpan Agarwal as well. Thank you, Savita ji, for your kind comments. Sitagliptin metformin can be taken after or immediately, or during or immediately before a meal. Usually, it should not upset the stomach. If it does, look carefully at the company that you're using, the brand that you're using, Dr. Arpan Agarwal. Try to get metformin sustained release. That will not cause a GI side effect. So some companies will be marketing sitagliptin plus IR metformin. They will not write anything, but the ones who have sustained release metformin will write it clearly. So sitagliptin plus sustained metformin, immediately before, immediately after, during. Usually, it should be all the methods should be fine. And thank you, Pratik. Pratik is my guardian angel. So like we have glycemic guardianship and glucometric guardianship, Pratik is my guardian. Yes, the next vitamin D talk is on 6th of March. So thanks, Pratik, for reminding me. Thank you, everybody, for being with us today. Today, we have spoken about glucose monitoring. Let us remind ourselves, urine sugar in a small percentage of patients, end of life. Only the elderly patients who are at the end of life. Don't prick them too often. SMBG, self-monitoring of blood glucose for virtually everyone, but a structured glucose monitoring in a rational way. The glucose monitoring pattern should be decided according to the therapy that you are giving and according to what you want to achieve. IPDM, Integrated Personalized Diabetes Management. Here, the glucometers are connected with the cloud, and they also give you an idea of like My Sugar app is there, MYSUGR, My Sugar app, that is free to download. So you buy the meter, you download the app, and then that will give you the trends. Apart from that, ambulatory glucose monitoring, which is also now known as ISGM, intermittently scanned CGM, and then CGM. And then again, HbA1c, usually 4 times a year, but it can be more, it can be less. And in some people, very few people, maybe a serum fructosamine. The brand that Dr. Arpan is saying is fine, and that's a good brand. It should be safe for the stomach. There should be no issue. From Dr. Nitin Narula, we have a question: which gliptin is the best? So all are fine from an efficacy point of view. Linagliptin is safe in hepatic and renal impairment. Even up till EGFR of 1, you can give it, even in dialysis patients. No dose adjustment is required. Vildagliptin, 1-step dose adjustment, 50 milligram. This is just to remember. If the EGFR is less than 50, 50 milligram OD. If the EGFR is more than 50, 50 milligram BT or 100 OD, that is vildagliptin. Sitagliptin will have 2-step adjustment. If the EGFR is less than 30, then sitagliptin 25. If the EGFR is less than 50, then 50 milligram sitagliptin. And if it is more than 50, then 100 milligram sitagliptin. So that is all you have to be careful about. Otherwise, all are equally effective. And welcome to Dr. Manu Sharma, who is from Delhi. CGMS, yes, certainly we'll take a session in the next season, which would be Diabetes Essentials 3. Thanks for pointing this out. So I'd like to thank everyone once again for being with us. And I'll hand over now to team FDC.
Thank you so much, sir, for giving us such immense wisdom and knowledge, sir.
Just remind about the sir. We can once again, because last whole week we have registered almost around 3,000 plus doctors for the special Ramadan week, which we have kept 3 sessions. And once again, reminding all our new registered doctors in our 52 weeks essential diabetes with Dr. Sanjay Kalra, which will continue even for the third season also. That we are having entire next month 3 sessions on Ramadan's, where we will be starting with Dr. Sahela Sheikh, and then we will be having Dr. from, I think, from Aligarh
Dr.
Muslim
Hamid
University,
Ansari.
and
Hamid
Hamid
Ashraf.
Ansari, sir. Hamid Ashraf. And then last session will be taken by Dr. Sanjay Kalra to end the comprehensive managing the diabetes during the Ramadan period. With this, I thank sincerely Dr. Sanjay Kalra, sir, for being once again on any other Sunday night. Thank you, sir, and Jai Hind, sir.
Jai Hind.